Thank you, Dr. Laila, for giving me this opportunity. And I would like to speak on ANET in children. As ma'am said that it's increasing now. So acute non-accommodative, acquired non-accommodative esotropia in children is a disorder of ocular alignment, which is characterized by non-accommodative esodiviation. And it develops after, it's not seen in childhood, it develops after 6 months of age. It is an otherwise healthy child. So it is occurring infrequently, but often raises concerns for the potential of an underlying neurological malignancy. So in a 10-year cohort study done by Mohani found that ANET is to be the third most common after accommodative esotropia and intermittent exotropia. So we have children with sudden onset esotropia and diplopia. Comitant, the angle of deviation is equal in all directions of gaze, and diplopia is a common and normal ocular eye movements. But remember, this does not rule out serious underlying neurological problems. So we have the types. We have the Swan type. So you have occluded it following monocular occlusion. Suddenly there is a disruption of binocular fusion, and suddenly the child presents with acute esotropia. You have the Burian-Franceschi type. It's around 30%. It starts between 8 months and 3 years, and there's also late start between 3 years and 8 years. They will present with acute diplopia, minimal refractive error, and they have good fusion. But mostly they are associated with some sort of psychological stress. Large deviation, but small refractive error. The third type is Belchowski type, 36.6%. This is esotropia which occurs in adolescents and adults with varying degrees of myopia. And it shows equal deviation and distance at and near. So basically it is uncorrected myopia, excessive near work leading to tension in the medial rectus and thus causing esotropia. Now, one variety is the type 4, which is associated with high hypermetropia that can be controlled with refractive error correction, and a type 5 where it can be associated with intracranial pathology. So if you have more than 2.5 years child, mostly second and third decade, diplopia, divergent insufficiency, you see nystagmus, A pattern, kindly do an MRI. Okay? So the clinical features of neurological AACs, mainly if they have hydrocephalus, you can have. There will be an infantile ET with an A pattern, and there will be a nystagmus and abduction. So you have a large angle ET, and you have divergence paresis. So if it's Chiari, this is an emergency because this needs to be referred to a neurologist very soon. It presents in early adulthood. You'll have ataxia, dysarthria, dysphagia, and divergence paralysis and downbeating nystagmus. Brain tumor you can again have, but in this case there will be a V pattern, and in contrast you may also see it associated with the 6th nerve paresis. A thalamic lesion, you'll have meiosis, and due to disturbance with the versions and fusional mechanism. So clinical history is very important. Time of onset, if there was any history of any physical or emotional stress, patching, any neurological illness, duration of near work, and history of preceding events. The management is refractive correction. If nystagmus, poor fusional potential, please proceed for an MRI, prisms or Botox injection, and surgical. So let us go cases. So this child presented with sudden diplopia and comitant esotropia in a child who had straight eyes, and we did a cycloplegic refraction, no refractive error, got an MRI done normal, so it is basically a decompensated esophoria. So in this case, it's simple. You do both eyes medial rectus recession, but wait for 3-4 months. Do not jump to surgery, and especially in a case of acute comitant esotropia. You have a child with diplopia, so you're not losing anything. But wait for some 3-4 months before you plan a surgery. So in that phase, you can, if there's a mild refractive error, you can give a refractive error correction or prisms. So the surgeries for these cases are very good with having good motor and sensory outcomes. So we'll have full restoration of pseudoacuity and resolution of diplopia. So now you have another case, excessive phone use during the COVID, and this has caused sudden onset of inward deviation since 1 year. And for this case also you do a both eyes medial rectus recession. Now this child presented is a 7-year-old, presented with a sudden onset of deviation. His visual acuity was 612. Got an atropine refraction done. There was a plus 6.5 in both eyes, gave him glasses. But even with the glasses, he had 50 PD for distance and near, and he had diplopia, which was corrected with so I gave him Fresnel prisms. Put on Fresnel prisms. So this is the Fresnel prisms where here you have Fresnel prism put in his eye, and for 2 months, and then operated, and then when he followed up in the visits, operated for the adapted angle. Suppose now your ESO increases, then you again have to change your Fresnel prisms. You may have to increase the Fresnel prisms and put another Fresnel prisms. So till the adapted angle, till we get the adapted angle is how much of esotropia is there to correct his diplopia. Till then you will keep the Fresnel prisms and then you will operate. And these children normally have good results. So case 4, this is a myopia with a -1 with a -0.75, 60 PD. The brain was normal, MRI brain was normal, and we did a 3 muscle surgery. So you see the variable cases. So now this girl presented, it was a 9-year-old girl who presented with sudden inward deviation of eyes, blurring of vision for distance and near. There was vertigo, binocular diplopia since 1 month. Her school got changed, and so therefore she was not comfortable with the new school, missing her old friends. So she was not on any medications and there was no history of trauma. Her visual acuity was 636 in both eyes, unaided N24. Pupil was normal, equal in size, brisk and equal reaction to light. There was a large comitant alternate esotropia, but it was variable, 35 to 80 prism diopters at distance and near. There were normal ductions. When we did a retinoscopy, the myopia was variable up to -4 to -5. Did a dynamic retinoscopy, there was a lead of -4. So what next step? Atropine refraction. So in atropine refraction, we found that the vision was still 624. Retinoscopy was only 1 + 1 cylinder with 90-degree axis. So it's a pseudomyopia. And the cover test still showed alternating esotropia and diplopia with no reduction in amplitude. Got an MRI done at normal, because even in these cases, you can have a neurological problem. And we diagnose this as accommodative spasm or spasm of near reflex, where you have excessive convergence with esotropia, pupillary miosis, ocular pain, photophobia-induced pseudomyopia, which disappeared with cycloplegic. We advised atropine 1% twice a day for a month, gave her bifocals because of the atropine. And then again after 1 month, for 2 months we gave her atropine, and we seen that there was no improvement. It was still 624 vision, N24. This, of course, the retinoscopy was +190, but there was still an esotropia of 60 prism diopters. So the next step was to give Fresnels. So we gave her Fresnel prisms, and because long term we found that we could not keep on giving an atropine, so we gave her Fresnel prisms, and then we referred her to the binocular vision therapy clinic. We have a very good binocular vision therapy clinic at Shroff. And we gradually, so they advised accommodation relaxation exercises, fusional vergence therapy with prisms. So we did around with Brockstring and single aperture rule. So this was done, and it was done with the prisms, and gradually we tapered off prisms and bifocal glasses. So what we found after 40 sessions was the child improved with 6/9 vision, and it was ortho. There was some esophoria with good control. And we found that the stereops also improved with 40 seconds of arc. Then we slowly removed her bifocals and prisms, and we also gave relaxation and fusional vergence therapy. So to conclude, it can be a varied etiology ranging from convergent spasm to those harboring serious intracranial diseases. So it is important for us to diagnose these conditions. So ACCE has a small but significant association with intracranial disorders. We also have to rule out that the possibility of an underlying intracranial disease should be kept in mind, especially in children presenting with acute comitant esotropia, because sometimes they may have an accommodative component, but we find there may be no neurological signs, but we still find they may have there may be some neurological disease. So we need to do neuroimaging, and we need a complete ophthalmological and neurological examination. So we can also rule out cyclic esotropia if it is cyclic, and myasthenia also, which can be also present. Thank you.
Thank you, Dr. Suma, for that wonderful talk. Do you do prism adaptation for every case with the ANET before you take up for surgery?
Most of the yes.
Or all esotropes?
Because what happens is that, so now if they're not improving, so now you have done an atropine refraction, and then you found that there is no refractive error, then I do give prisms. So not for just for prism adaptation, but a Fresnel prism just to know what is the adapted angle for with the diplopia is getting corrected. And I also do not want to operate just at 1, 2 or 3 months. It is better to wait for 3, 4 months in acute comitant esotropia. So prisms is helpful. So when once you give the prisms, then the child comes back, and then sometimes you find that the ESO has again increased. So at least it tells you that the what adapted angle which you operate. Because if it increases, then again you'll have to give another Fresnels. At least your surgical outcome will be more than 90%.
What about the role of Botox in the early stages? When
Yeah,
they
there
come
are
to the-
papers, but I'm not giving Botox. But there are papers if for Botox. I think it will be helpful. There's no, I don't think it should be a contraindication. It can be given. Botox can be given if you find that if the child is cooperative or, I mean, suppose in an adulthood, like in 12, 13 years, you can give Botox.
Any questions from the audience? So shall we move on to the?
You said it is for children. If esotropia is there, they are presenting with
Mic is
diplopia.
not working, I think.
But if any adult around 18, 22, they
Yeah.
are coming, and they are still complaining of diplopia even after prism adaptation test. So what to do? Fresnels, and how much time actually will be waiting, or how frequently we are supposed to see them before going for surgery?
Yeah, so suppose now it's an adult, like mostly this Belchowski type, they're mainly adult patients, like myopia with esotropia. So you give Fresnels. If you find that with the Fresnels it is not becoming, the diplopia is still not, then maybe in those cases you can do a trial of Botox and then go for the final surgery. Or because it should fuse, why should it not fuse? Because these are good outcome cases. And so it should fuse with Fresnels. So if say about after 3, but if what happens is that sometimes in PAT, the esotropia, they're eaten up. You get more and more esotropia every time when the patient comes. So you wait, you give them, if they can afford, of course, because Fresnels also expensive. But I think you should give another Fresnels and tell them to come with a new Fresnels. Say suppose if it's 50 and you have gotten your next visit 60. If they can afford, then you can give another prisms and again call them after 1 or 2 months. If they can't, go in for a 60 prism surgery.
So how much actually time, okay, it has become stable, so how long
Yeah,
should
4
we
to 5 months I operate. After 4 to 5 months, because it's not practical for the children, for the patient to carry on life with diplopia. And
do they come back
yeah.
Yeah. Thank you, Dr. Suma.